All right. Hello, everyone. My name is Marielle Malana. I will be your host for Global Ground Rounds today. Today's presentation is CME proof. So if you would like to receive CME credits for this presentation, please click the link. We have our Global Ground Rounds medical director here, Dr. Pekia, who will now be introducing our lecturer, Dr. Gill.
Thank you, Marielle, and for all of the global offsite care volunteers dedicated to Global Ground Rounds and continuing the series of these presentations about the applications and settings in which remote and extended telehealth and telemedicine can benefit patients and their communities. So I'm Dr. Gregory Pekia, Medical Director at Global Offsite Care and of Global Ground Rounds, and also a assistant professor of geriatrics and family medicine, and direct the course in telemedicine at Western U. Our speaker today returns. Thank you so much, Dr. Gill, for this. I think maybe our third or fourth session together. Dr. Gill was born and raised in Pakistan, went to medical school at Lahore in Pakistan, and completed his internal medicine residency from NYU in the US. He's been a hospitalist for about 14 years now, and the majority of his time currently is spent in addiction medicine practice. His passion is pain management and addiction medicine, and he shares with us a fun fact that he, quote, loves to paint acrylic and oil on canvas. So with that, Dr. Gill, I'll hand it over to you. And again, thank you for being with us today.
Good morning and hello, everyone. Thank you for having me, Dr. Pekia, and for the introduction. I'm humbled by that. Right, so today's topic I chose for various reasons. The pandemic, it's an epidemic. I call it pandemic. The epidemic of opiates use that we are currently facing in the United States. This is going to be an overview. Today, our learning objectives will be just to understand the difference between addiction, a certain terminology, clarification of the diagnosis. We'll just go quickly over essential components of medical model for substance use disorder, and quickly go over interviewing skills as well. Before we begin, we'll have a little fun fact. Actually, I wanted to send this out, but I thought that I will speak about it. Can we start the slideshow? Or do you want me to start this slideshow, Marielle?
Yes, if you would like to do that, or if you can, I'm able to do that.
Okay.
So it's up.
Hold on, let me pull. All right. So chronic pain and substance use disorder. Now, I want to clarify that the pain is real. That's a really important statement that I learned 3 years ago while I was at Sonoma Specialty Hospital. That hospital provided me opportunity to work with dual diagnosis. A patient was staying for a long term, and a lot of them had substance use disorder with a lot of other co-occurring medical and mental health disorders. So it changed my approach and understanding about pain control and chronic pain management and addiction. Now the substance dependence, which is essentially, we will be talking about opiates today, focusing on opiates. The addiction or substance dependence encompasses a lot of substance, a variety of things, right? And we did have patients, not only opiates, but usually opiate dependence or opiate abuse accompanies other substances too, because now that the addiction pathway has developed. Okay, so pain is real means that the pain complaint is subjective. And a lot of times when we do the documentation, we are documenting drug-seeking behavior, pain-seeking behavior. That's misnomer to us in the addiction medicine field, because when we understand the how the hyperalgesia, for example, happens, pain is real. Okay, so we will go over this quickly. A fun fact, about 4000 BC to 1500 BC in Egypt, when Pharaoh was using his slaves to build pyramids, they were awarded with beer. However, they were also alerting them that getting drunk and irresponsible, how you could become incapacitated. And I think the current advertisement that we have, drink responsibly, I can relate it to 3500 BC, when these hieroglyphic language, and the translation was done by WHO, that this language shows that you should drink responsibly and be careful. So you see, since the beginning of the time, the substance dependence addiction has hit every single part of the society, every community, since the advent of out-of-mind experiences or psychoactive drug use. One way or the other, every part of the world has been exposed to one or more addictive behaviors. Right. So today we will discuss briefly what substance use disorder is. Substances usually classified in 4 major categories: uppers, downers, and all-rounders. And now we have added a 4th category. Usually there were 3 of them, but 4th categories: other substances and additives and medications and so forth. Addiction doesn't only stop at the area of addiction. Medicine does not stop at substance use disorder. There are a variety of other behaviors that are as addictive and harmful as substance use, can lead to social, financial, psychological, interpersonal, and legal problems. Sex and love addiction. There is a correlation of addiction to these behaviors with drugs, eating disorders, anorexia, nervosa, bulimia, binge eating. These behaviors can get out of control, turn into impulsive behavior, and becomes a problem with all aspects of life. Gambling. Now current books of addiction medicine carries topic on electronic addiction, pornography, and a long list of things that come along with the electronic addiction, especially since the COVID-19. The opioid epidemic has become serious. Nearly 1/3 US population engage in risky use of substances. In high school, 1 out of 10 are trying substances. 1 out of 7 go into full-blown addiction diagnosis. The overdose deaths, majority because of opioids, climbed to 109,000 in 2022. The substance use disorder affects 45% of people seeking care. So people seeking care at the clinic, 45% of those people have some sort of substance dependence, but it's not recognized. We fail to screen them appropriately, or like I said in the beginning, we are calling them drug-seeking behavior. we will talk about that mainly for today's lecture. There are about 6,000 deaths yearly in California. California is the fifth state in annual death rate. Now, the important thing to remember is to observe is that the death due to overdose is among those people who are under 44 years of age. So at our clinic, where we practice, we have families walk in. In my experience, the past few months has been really surprising that we have a mother who's dependent on opiate, and she has accompanied by a 13, 14-year-old child who's also dependent on the substance and asking for help. Well, we only adult serving adults, and therefore we turn them away and send them to pediatrics, but that's bad it is. So under 44 years of age is the majority of the people that overdose. You can see how much workforce and the cream of our society is being affected and dying, actually. The heart disease related deaths are between 64 and 70 years of age. Our death due to overdose is 35 to 44 years of age. It's important to know this terminology. When we see patients in the clinic, when they walk in, how do we behave? What am I telling my patients, that what's my understanding about all these terminology, or how I speak with patients? For example, we call them harmful use or hazardous use or at-risk use. And we call them addiction or substance use disorder, right? We try to avoid saying you're an addict, you're an alcoholic, and we don't call them junkie and crackhead, but this is sometimes when patients say that, we'll tell them, hey, you are a person with a substance use disorder. And try to avoid binge drinking, messed up, smashed drunk, your urine is dirty, we call them intoxicated, you prefer to say words unfavorable, medication dependence, and abuse, not abuser. So some, if patient is drinking alcohol and getting drunk, for example, when we screen them, we will talk about the cage question or cage 8 questions that we ask them in a way, or we express in a way that we show empathy and not use this terminology. It's important to include, like I said in the beginning, the pain is real, and it originates from several points and etiology. If we classify it into several categories, it sort of give us a little bit better picture, and we what we try here is to separate complaint of pain from immediately it's a drug-seeking behavior, right? So pain can be somatic, like skin and reasons related to it. Visceral, the pain from bone is quite different, and fractures and so forth. It's referred pain. Now there is something called central sensitization and fibromyalgia. That is real pain. Hyperalgesia is one of the reasons that causes that our threshold for pain goes down. That the same endorphins are failing to act on our natural opioid receptors, so that there's hyperalgesia. Patient is feeling a lot more pain. They're hurting where they didn't hurt before, and even though they are not using substances, right? Mental health, depression, for example, and now the opioid withdrawals, dependence. We also include cancer, patient with palliative care, end-of-life care. That's where real pain management can make big difference for the quality of life and patient's condition. There's difference between harmful use of substance and addiction. Addiction is defined as a chronic relapsing disease. There's an obsessive and compulsive behavior of using despite consequences. And if they don't use the substance, it turns into an emotional, negative emotional state. Okay. So that's the definition: negative emotional state, obsessive use of substances despite consequences. Now we have determined that there's an epigenome. 40 to 60% people had genetic predisposition already. The rest of the 40% is what environmental. They get exposed to certain substances, and their mind gets clicked to one substance. There's still a lot of work to be done to find how does one person find its substance of choice, right? So they're trying alcohol, opiates, and marijuana, for example, but alcohol clicks to one person and opiate clicks to another person, and they obsessively start seeking that substance. The other factors, neuroplasticity, their ability to regenerate their neurons, physical development, environment, age of first use. They all define when someone is using a substance which is considered harmful use. For example, a teenager using marijuana or getting drunk every weekend. Now, it probably won't fall into a full-blown addiction definition. However, he's in the category of harmful use of substance. And if we catch it at that level, we can prevent it to going into full-blown addiction. That's why it's important to separate both behaviors. That is it a harmful use, or whether person is in full-blown addiction. And so then the treatment for addiction is complex, and it involves families, from physician to nurses, and government services. Long list of consequences, of course, physical, mental, financial, interpersonal, legal, and all sort of things that comes with addiction. So this is how it starts: the environment and the biology. See, they both, the 60% genetic, the rest is environment. It's really important what their history is. Like, take their history, their family structure, how their income, what they went to school, what their understanding, all these things which we catch during interviewing. Then we go into what they're taking right now, what they're asking you to prescribe. Then age of early use. This is the drug factor, right? This environmental factor. They're already genetics, like basically they're already born with. And biological or genetic factors are not all negative. It's interesting that we'll see that genetic factors actually could play a positive role into an addiction. Pretty soon I'll show you a scan, and we will have that finding. Okay. All right. So anatomy of addiction is important also to understand. There are 3 stages of addiction. This one, the first stage we call incentive salience or intoxication phase, when the substance is introduced, creates euphoria. It starts from, it's a mesolimbic system of dopaminergic predominance, and also includes epinephrine, norepinephrine pathways, endorphins, and a lot of other neuronal systems. It's a complex process. However, clinically, so it creates euphoria. This starts from midbrain, where the what we call it a VTA, or ventral tegmental area, and from here these neurons go to prefrontal cortex, and then from there it connects back with the amygdala and limbic system. Limbic system is responsible for emotional states. Okay, and prefrontal cortex of executive area is responsible for decision making, and subcortical area just underneath the prefrontal cortex is is a motivational drive. So when the ventral tegmental area pushes out, gets excited by the substance use, and that's how the addiction builds. That's how it catches, when the brain catches for certain substances. Now, if it doesn't work, for example, this dopamine or mediated mesolimbic system does not get excited by any substance, the person will not go into addictive behavior or impulsive use. So that's the basis that how certain substances become addictive substances. This quickly, how the addiction happens. The first state is the intoxication, and then stress or feed or withdrawal that comes from amygdala, and then preoccupation, that's the cortical state. So in the three states, the intoxication, emotional response, positive one when the drug is there and the drug is taken away or goes away, or the receptor down regulation happens, or they just run out of dopamine, so negative emotional state. Then the negative emotional state then sends the signal to the motivation and frontal cortex, where the executive function is. So basically, person start planning, thinking how to obtain, and person start ignoring responsibilities and other things, all the responsibilities other than drug seeking, and that's definition of addiction. So it starts from an idea. The belief is important. Peer pressure. Try this. Try smoking this. You will feel great. You will have a lot of mind experience. So believe, placebo effect, action, reward, dependence. So if we can break anywhere and able to stop, we can potentially stop developing full-blown addiction. It's a mesolimbic systems, substance of choice versus substances. Again, a lot of factors function here, like comorbid mental health and illnesses. Somebody's depressed. For example, opiates via the delta receptors are actually antidepressant. They do give euphoria. The stimulant have this rush and elevation of mood. Some people get dependent to choose their substance choice as a stimulant versus downer, so upper versus downer, versus psychoactive or all-rounder like mushrooms. So it really gets dictated their belief, their genetic predisposition, and how their brain is developed, turns into a substance of choice. The expectation versus pharmacological effects, for example, same definition as placebo. Can we go back? Yeah. Okay. All right. I'm gonna have a little challenge here. How shall I go back? Let me stop the slideshow and then start again. Sorry about that. Do you want to take the, you're going to get into driving seat, please?
Yeah, I'll share my screen. Give me a moment.
Yeah, thank you.
Yep.
So going from here, we have actually a medical model that we have developed.
All right. Do you see my screen now?
Yeah, I do.
All right.
Okay, so, okay, wonderful. Thank you. All right. So we were, let's go. We were discussing the how that the chain of it starts from idea, goes to all the way to dependence. So all depends on genetic factors and environmental factors, patients' development, using history and neurocircuitry, how the neurocircuit is built, the modulation. What's withdrawal? It's it's the blunted euphoric response. Right? I have certain terminology because this lecture is really sort of an introduction, and I have tried to target our med students and general practitioners. So withdrawal, when we call it withdrawal, is really the lack of the same response that our memory and prefrontal cortex and amygdala has been receiving before, but they're not using it anymore. Next slide, please. Yeah, thank you. So addiction, a chronic illness, that there has been a lot of debate in the past few decades. And it was considered a moral failure, willpower, and all sort of things, and still does. And still to this day, I have to give this understanding to patients and their families, talk to them, give them example. And we back this definition through a study. Diabetes, hypertension, asthma, they're incurable chronic medical illnesses. Now, when and it was a study in JAMA in 2000 showed in a large number of patients that adherence to medication was less than 60%, adherence to diet and behavior was less than 30%. And when it comes to substance use disorder, which is a chronic illness which can't be cured but can be treated, when someone is treated for substance use disorder, gets treatment for rehab, or come to the clinic, or clinic-based or hospital or institutional-based treatment, after discharge, their adherence was less than 60%, similar to diabetes and hypertension. And how do you define abstinence is when they remained sober, or not using the substance, or not returning to use for more than a year. Next, please. Substance-related disorder, important just to know, intoxication, withdrawal, delirium, dementia. There are some pathological processes happen with certain drugs, stimulants like cocaine, methamphetamines, for example, these psychedelic drugs. So they do, for prolonged use, does turn into permanent structural change and lack of executive function. So dementia, amnestic disorder, mood disorders, anxiety, depression, sexual dysfunction, sleep disorder, and insomnia, sleep disorder itself is responsible for a list of mental health disorders like psychosis, depression. There has been a study last year came out that how insomnia was one of the big factor in suicidal attempts. Next slide, please. So yeah, the treatment works. This is a PET scan, a metabolic scan of the brain. This is person with no substance use disorder, and see these are mesolimbic areas are lighten up, and someone goes into methamphetamine addiction, depending on how long they've used and all the factors we just discussed, the factors they're born with, then their behaviors. After a month of abstinence, functions start to return, and at 12 months, it's almost normal. And usually the neuroplasticity or the regeneration of neurons take about 12 to 16 months. So when someone is over 12 months, we call them sustained remission, that there is a high chance that patient will not return to use. Next slide. This is the slide that that really was very interesting to me. This is a PET scan of 2 people who had active addiction for alcohol, active drinking behavior, regular drinking behavior. Now, the left, if you see the left scan, that person has come from a long family history of alcoholism. And you see there is this, he's evolved, there is adaptation in the mesolimbic system. There are a lot more dopamine receptors and activity to in that brain, and because of the receptor and neurotransmitter upregulation. And the person on the right has no family history, so he's genetically not adapted. So what happens if this on the left, this person start drinking because he has a lot more dopamine receptors, so the negative or withdrawal surfeit or the negative emotional state will not be achieved compared to the scan on the right. If they both drink the same amount of alcohol for the same duration, this person will go into withdrawal or negative emotional state and start seeking compulsive drinking compared to the person on the left, because he still have a little bit of more dopamine that keeps supporting him, so potentially will not slip into compulsive behavior. So this is one of the examples that how genetic factors, if bring someone to development of active addiction, actually protects that person from alcohol addiction. Next slide. Again, terminologies. For the starters, I'm very fond of talking about this. It's important to know hyperalgesia exists, and when we talk to patients coming to the clinic, we should be able to separate what's going on here. Is the patient actually hurting, or is this something development of full-blown addiction? The abuse, dependence, cross-dependence. Abuse is when we give prescription. If you talk to the person, I gave you 30 pills, 1 pill a day, it's been 30 days. How come you ran out 7 days ago? When you say that, you approach them. So let me talk to you. Can you tell me what happened? How did you use more than prescribed? Were you hurting a lot more? And then you take more history and then reflect back and ask patient to once the history is taken, ask patient to reflect back. So pain control, hyperalgesia, that's real, and that's how the addiction actually works. The opiate, the same amount of opiate when you give someone, there's a downregulation of the receptors, and person thinks I need to take more for the same effect. And then hyperalgesia happens. Patients who take sporadically opiate pills and stop within 4 to 6 weeks, less chance of building a dependence. We go beyond that, a high chance of building dependence. Cravings are important terms. These are cues and triggers. That person has strong introspection. The brain tells you, you need that, right? This poor inhibition leads to executive functional deficit. And glutamate or glutaminergic neurons perturbation is often found to be the reason. The euphoria, high intoxication, that's basal ganglia, mental area. Next slide, please. Let's have a little overview. This is the whole, we can talk books over this topic, their metabolism, the substances. We generally divide them into downers, alcohol, opioids, sedative hypnotics, the GHB, benzos, muscle relaxants, and then there are uppers. So downers, what downers do essentially, usually opiates, for example, work through the mu, kappa, delta receptors, nociceptor receptors that are present in the amygdala, regulate emotional response. They take the inhibition away, brings down the anxiety and sense of euphoria. And the uppers give rush, dopamine, epinephrine, elevate emotional state, and hence by doing so, make the brain disinhibited. All-rounders are ketamine, cannabis. They have both downward and upper effects, plus hallucinations, and gives delusions. So it's a mix of everything. We call them all-rounders. And there are a ton of other substances like steroid abuse, the steroid rage, the tyneptine, for example, the xylazine. Xylazine is currently put in the fentanyl. It's actually it's something what they call it cutting. Patient come with, and the worst part is we can't test it. We so far have not developed testing mode for someone using or abusing xylazine. Xylazine is all-rounder. It gives a sedative, hypnotic effect, opiate related, as well as methamphetamine or upper effect. So this currently being the hot topic in addiction medicine community. Next slide, please. Substance Abuse and Mental Health Administration Services has developed a medical model, and one really important portion is to determine what patients' views are. Right? How do patients look at the addiction? For example, when in the beginning, patient thinks that he's hurting, and now what's becoming the hyperalgesia come into play, the downregulation and poor opiate response. Now patient thinks that he needs that. So starts from prescription to I need them. Right? Then there are mental health issues, and go to friends or start self-medicating. There could be trauma, it's sexual, physical, emotional. 97% of victims of sexual trauma have been reported to use one of the addictive substances. So they're trying to feel better here. Criminal justice system and society, big responsibility, how we look at how the incarceration happens, and how I don't want to go into detail of our flawed criminal justice system. It's responsible. Somebody goes to jail, gets exposed due to multiple factors. Doctors' reflection is very important as well. We know that we are being manipulated. Sometimes doctors hopeless, we sometimes fail to show empathy with our fast clinic routine and appointments. So all these things that physicians can improve, you should have a self-reflection about. Okay, next slide. This is the model, we call it as SBIR. That's a medical model built by Substance Abuse Mental Health Services Administration. Starts with the screening. So that's first portion. The screen for substances like tobacco, alcohol, and you can use various ways like cage, audit. There are many different screening modes are available online. You can go to this website and you can look for that. Motivational interview. When you have anyone with mental health, personality disorder, social, legal, medical problems, having HIV, hepatitis C, syphilis diagnosis, and irresponsible intimate behaviors, it's time that you screen. Okay. And high-risk areas are adolescent healthcare. They're usually overlooked, and chronic pain. Anyone suffering from chronic pain should be screened periodically, whether they have slid into a full-blown addiction. Next slide. Brief intervention, that's the second step. Once you have discovered that patient is at risk of addiction with the behavior. So you determine whether it's a risky use of substance versus addiction. Now that addiction has been diagnosed, whether an office-based treatment would be whether versus referral to a institution. You can have further learning about that, and the SAMHSA website has all these different modules available for training general practitioners. It's a multidisciplinary approach. What do we need to accomplish? Understanding patients' side, like I spoke earlier, have patient understand what's going on, remove barriers from our side, from our staff, from the clinic, the front desk to physician, discuss benefits of abstinence. There are different modules, harm reduction versus full abstinence. Next slide, please. The treatment, it's a big topic for a short lecture. We can just, I can just go over quickly. Opioid use disorder or polysubstance use disorder. We use currently buprenorphine, methadone, naltrexone, and we just received a study at National Institute of Drug Abuse that actually the methamphetamine users and their cravings can be treated with buprenorphine, or buprenorphine use can improve the craving or resolve craving for methamphetamine as well, beside opiates. Stimulant, use different options. There is a what we call metrics module being used for stimulant use disorder, and cannabinoid receptor blockers that used in Europe, not in the United States. I couldn't find any drug for that. Alcohol use disorder, benzodiazepine use disorder, mental health and dual diagnosis. They are independent or interdependent, so screen for mental health disorder and refer them to the either psychiatry, or you can do the general psychiatric care at your clinic. Next slide. Other parts of addiction area, the sports, athletics. I thought to just quickly have a slide about that. What kratom is a actually opioid-like herb or a substance that our patient use, and it leads to similar features of opioid addiction. So patients use it outside to do self-treatment, but usually don't work. However, it does have effect of opioids. So it might treat withdrawal, but might not take them out of addiction. Gambling, eating disorders, obsessive, internet surfing, hoarding, shoplifting, all. The altered neurochemistry, the same between substance use disorder and non-substance addiction. Okay. Taking a cocaine user and gambler, they both use the same mesolimbic system to satisfy their cravings. Next slide. And every thought and every action has an impact on the brain. That's the fact, right? And it's so interesting is that the same thought brain create itself, loops back on itself. Some people argue that thoughts could come from outside of the brain. I'll leave it up to you. Questions? We are done. About 11 more minutes that we can discuss. Anyone has any question, want to discuss any part of the presentation? I hope.
You bet. You bet. Thank you. I'll start with a burning question I've had. And again, thank you for the presentation and the thought-provoking update on approaches to dealing with a variety of these substance use disorders. And we did, for those of you new to Global Offsite Care and Global Grand Rounds, we had a presentation a few years ago from a practitioner of the art of addictionology who had a fully remote practice. So the idea was that he was bringing chronic pain management and opiate overuse disorder treatment to the patient using telehealth tools. And it's just fascinating, and probably one of the few at the time doing that. Since then, we've had an increase in bandwidth, and of course, post-pandemic, a more ubiquitous use of these tools for communication with patients. And we've had a couple of digital therapeutic tools that utilize internet connectivity for FDA-approved treatments of opiate overuse disorder and other substance use disorders. So my question is, from your experience, I assume that most of your practice is currently in a facility environment with the patients and the clients coming to the facility. What have you seen that may or may not open the opportunity to increase the availability of such services to individuals who may not necessarily be able to overcome the barriers, the social, economic, and political barriers to gaining access to services like those that you're providing?
Very good question. It's actually a big problem. Creating, I'm going to focus on barriers actually, that telemedicine actually can be really helpful, because again, the stigma, the understanding of people, even in the medical community. So the treatment seeker wants to hide all that treatment. And so it starts with education. So we should be outreaching, teaching society and medical community how addiction works and how the treatment is available and what treatment does. Now, having that should be really the goal of ours. Now, telemedicine has helped so many people, especially like I would like to include those patients who live so far away from treatment centers, in remote areas. So they have access to these services. And however, for example, opiate addiction, there are not many options on telemedicine. The option is usually mental health related treatment, like anxiety, depression, co-occurring mental health disorder. And there's a buprenorphine right now that we are utilizing on telemedicine. And the reason we are able to do the buprenorphine, because buprenorphine is not considered to cause overdosing, because it's a partial receptor, so it does not cause respiratory depression. So we can safely prescribe patient, combining it with naloxone, so they can take home. There are not many options for them otherwise to utilize. However, just buprenorphine is making huge difference preventing overdoses. Especially for harm reduction, we can really utilize telemedicine. There's a difference between harm reduction approach and full abstinence approach. Harm reduction, when we leave it up to the patient whether they want to continue to use a substance, we don't investigate the urine toxicology or ask them to meet the treatment criteria, and that is preventing overdoses. I'm working in a harm reduction group every week, and it's a large number of patients from California that I see, and it's clearly, the study showed that the more buprenorphine prescription a patient takes, the death rate goes down. So yes, many ways it's very helpful. However, the state and federal authorities, they would try to restrict these services. Discussion started in this March 2023. The decision will come in September. We have time until September. Currently, I practice personally in the clinic, a methadone, buprenorphine, addiction medicine clinic. In the morning, evening, I take care of patients online, including harm reduction. So I do telemedicine, and there are tons of advantages doing that. And like you mentioned, in my telemedicine practice, I have nursing supervisors who are running the large facilities, there are healthcare workers, there are lawyers or people who don't want to walk into a clinic and then being seen, oh, he's walking into the clinic, because addiction affects every single person, and without exception. So yes, the answer is absolutely. Yeah, anyways.
Right, thank you. Yeah, appreciate that. All right, other questions? We have a couple of minutes. Just raise your hand or speak up or
So I have a question
Dr.
or a
Ross.
comment. And Dr. Gill, I appreciated your presentation. Learned a lot about keeping organized in my thought process. But there were a couple slides in which you mentioned that diabetes and hypertension are incurable. And I would like to challenge that notion by telling you that I've treated and seen a multitude of patients who have actually reversed their diabetes and their hypertension by changing their lifestyle choices, and particularly the foods that they choose to eat. That means taking people with a hemoglobin A1C in the 12, 13 range, coming down to normal and continuing in normal for months and years. Now, I'm not talking type 1 diabetes, I'm talking type 2. And so I guess I would just plead with you to consider reviewing the current nutrition science literature and lifestyle medicine literature as you move forward, and use comparisons. Just my thoughts on this, and it's a challenge to you.
Do you want me to respond?
If you'd like, you don't have to. I'm very passionate about this topic, and the public is very confused about it.
Let's say we have type 1 diabetes, that's incurable, right? So once someone runs out of insulin, they're not going to produce insulin, right? I do agree what you mentioned, lifestyle changes. So if someone is at syndrome X or early parts of diabetes, when they still have insulin, there is production of insulin. However, they're not able to regulate it. And we all know that insulin regulation doesn't only, it's not limited to pancreas, it's liver, kidneys, and fat metabolism. So I can relate it to harmful use of substance and full-blown addiction to an early part of diabetes versus full-blown diabetes. So I would relate it to that way. And this is what this study showed. People who had full-blown diabetes, and it's not in the early part of diabetes, and people with full-blown addiction, not in the first, their harmful use while their brain is getting wired and the new brain connections are building between the mesolimbic system and prefrontal cortex. It's the same process how the lack of insulin develops into full-blown diabetes.
Thank you for that. And that brings us to the end of our hour. For any other questions or comments, feel free to send them along to me. I've put my email in the chat. And also, again, thanking Dr. Gill for sharing his time and knowledge and expertise in this area. And with that, I would remind you, we'll be back next month with an additional entry into this series. And I will then hand it back to Marielle to close.
All right. Thank you, Dr. Gill, for your presentation. And I just want to remind everyone that if you want to have CME accreditation credits, please use the link that I put in the chat. And if you are interested in presenting, please feel free to reach out. I also put the email in the chat box. Our next Global Grand Rounds will be on August 9th. And as always, we appreciate your participation and continued interest in Global Grand Rounds. Have a great rest of your day, and we hope to see you again next month. Thank you.